Yeah, Michael, Chairman, ladies and gentlemen. First, I'd like to thank the organizers and specifically my friend Clinton for inviting me and letting me speak about a topic that, well, I have to go back a little bit and sort of set the stage. And so I want to go through these points with you and sort of repeat a few things in order to understand that you can see what my points are. So is aortic stenosis a problem? You all know this picture. It is. So pressure gradient has symptoms at one point in time, and then it decreases your life expectancy. So how do we assess the relevance of a stenosis? And we do this by two ways. One is the Bernoulli gradient, so that's just flow assessment here, and by this principle here, then you can assess the gradient that you get, and then you have the continuity equation where you derive the effective orifice area from, and that is sort of the principle that the product of flow and area here is the same as the product of flow and area here, and that is the effective orifice area, and that's the outflow tract area then. So the effective orifice area is a virtual area that is there, that is generated through this flow assessment and this mathematical relationship. So this is important to understand. So if you then correlate effective orifice area here on the x-axis and the mean pressure gradient that's derived with the Bernoulli equation, then you see this relationship. And that's very clear because we all know that at 1 centimeter square of effective orifice area, you all know this value, the pressure gradients go up if you go below this. And that's when you have your indication for surgery, and that's when we treat. So that's before surgery. And so now if the effective orifice area is used for decision making post-operatively, and pre-operatively, then we have introduced the AOA index. So that is the effective orifice area, as I've just explained to you, divided by the body surface area. And that is due to a very old idea of Eugene Braunwald. And I talked to him personally a few years ago, and he told me that the idea was that a mouse doesn't need the same cardiac output as an elephant. So you have to relate it somehow. So they used the body surface area at that time. And that works well for indication, for selection, because you have high grades of stenoses, and then you can direct that. So then, of course, what is the therapy of choice for replacement? If you have your indication, you replace it. You use a tissue valve, you use a mechanical valve or a transcatheter valve, whatever you want to do. But somehow, always some residual gradient remains. And then we have to ask the question, and we have asked that question in the past, and you all know Pibarot's activity here in 2003, that he introduced the PPM assessment. Rahimtullah introduced that concept that if the valve is smaller than the native valve, that's prosthesis patient mismatch. And if you quantify that, that was Pibarot's work, and if it's not significant, that's greater than 0.8 centimeter square per body surface area, per square meter body surface area. And then you know these three things, and then you see here in this initial publication how mortality risk will go up if you leave a gradient. Okay, so everything's clear so far. So my point was that how effective is effective orifice area related to body surface area if in those equations there are patient-specific parameters referred to twice. So you have your LVOT area, that is specific to your individual anatomy, geometry, and then you have your body surface area that's also specific to your, but it's a different value. So I think that it just camouflages things. That's sort of my impression, because why dividing it? Because the anatomical relationship is already in there. So let's see what that means. So we looked at papers that published on PPM, impact on mortality. And you see here, you don't need to read this, but you see PPM relevant or PPM not relevant. And you see just as much ink under those two lines, and there's big confusion. So EOA, back to this. What does that mean in terms of relation to the valve? If you have a valve implanted in a patient, implanted like this, then your flow is being compressed. That's your valve opening here, your geometric opening of the prosthesis. And then, because of the flow compression here, you will have your effective orifice area ending up somewhere, being not necessarily the same as the effective orifice, that's the geometric orifice area, because the compression may result that the highest point of flow compression is behind the actual opening. So you have your effective orifice area here. So if you implant the same valve into a different anatomy, and you use different techniques maybe, however, let's say we have implanted this valve in this anatomy, in this fashion. All of a sudden flow is better, and you derive a different effective orifice area from the same prosthesis, just because the anatomy of the patient is different. Okay? So what is the recognition from this, and this is very important. The effective orifice area is patient-specific. It is not prosthesis-specific. So let's say a practical example. You have this guy, he's 190 centimeters, 100 kilograms. His body surface area is 2.3. This guy is 30 centimeters shorter. His body surface area is also 2.3 because he's bigger. So I would argue that the anatomical dimensions in these patients are different, because I would think that he has different greater aorta, greater outflow tract, because the whole guy is bigger. And this guy is just, he has smaller everything, but he has just a lot of fat, and that creates this greater surface area. So now we have developed in the surgical field something called projection of the effective orifice area. So what we do is, we use the effective orifice area that we measure in this guy and divide it by the BSA from the patient in this guy. So all of a sudden, you have, of course, it's obvious that you have different EOAs depending on the different anatomies. But if you say that this effective orifice area that you measure here will also be available here, that's wrong. So if you look at this, and now you see red and green, these are all the publications that we could find on patient prosthesis mismatch. And look at the red, those are all projected EOAs. 80%. 80% of studies use projected effective orifice area to assess PPM. Only 11 measured it. These charts, you all know them, have been provided, and people select valve size based on this. These charts are not useful because they think that the Magna Ease, the Mosaic, whatever you call it, has a specific effective orifice area for a specific valve size. But again, the EOA is not valve or prosthesis specific, it is patient specific. So the conclusion is our current way of assessing PPM is based on a questionable logic. So we relate with the indexation to two patient anatomic factors twice. And then we have a systematic error, and that's the projection. So the PPM charts, they demand EOA projections. So please throw them away. They're not useful. So does that mean that PPM is irrelevant? And now this is a paper from Mark Ruel. He actually is a few years old, and he looked at this, and he looked at predictors of all-cause death, significant independent predictors. There's no PPM. You can't find it. You find it in the non-significant variables here. It is not significant. Mismatch. So it's not important for survival. But maybe it is for symptoms. So he looked at New York Heart Association class 3 or 4. And he finds significant independent predictors in vivo effective orifice area here. And you can see they're just significant. So symptoms, okay, but not mortality. Maybe it's not big enough. So we'll see. So how should we go on now? I mean, it's a big mess. What does it mean? So what we did, we performed a literature search, and we looked at all the studies that presented post-operative effective orifice area measured in the individual patient plus the pressure gradients. And we related that. And as you can see here, this is the image that I showed you as pre-op, where you had after 1 centimeter square, there was this. And this are all the numbers we could find post-op in all these different studies that we had. And what happened was that after like 1 centimeter square, this relationship of these things, you could, whatever mathematic equation you could put through was always highly significant. So that means there's also a linear relationship here that would fit. Okay, so now comes the next thing. If mean pressure gradient and EOA obey after 1 centimeter square here to a more or less linear, pseudo-linear, whatever you want to call it, relationship, then I would argue if there's this linear correlation between pressure gradients and EOA after AVR, why don't we relate pressure gradients to body surface area? You got your pressure gradient after surgery, it's 30. We divide it by 2, it's only 15, no problem anymore, right? Nobody would do this. You would never get to the idea to relate pressure gradient to the effective orifice area. But we do it with the pressure gradient to body surface area. But you do it with the effective orifice area. So I said, if there's a linear relationship between pressure gradients and effective orifice area after valve replacement, why don't we use the pressure gradient, the remaining pressure gradient, for hemodynamic assessment? Why bother measuring EOA if I can use the pressure gradient as it is? And let's go back to the Ruel paper. And I've shown you that for symptoms, he had EOAI, the effective orifice area index, found to be relevant, significant for PPM, right? That was PPM was relevant as assessed with EOAI for symptoms. And the statistical significance here was barely just under 0.05. So if you look at pressure gradient in the same study, look at the p-values. The precision to determine your things is much higher. Your p-values are much more accurate. So you're basically, my point is, you're camouflaging your precision of assessment by measuring EOA and relating it to body surface area. It's not necessary. You can do it, but it's you're much more precise and much better if you use pressure gradient. So pressure gradient alone seems to be much more accurate for assessment of clinically relevant hemodynamics after AVR than the EOA or the index. And the residual gradients may cause heart failure. So which factors does valve type play then? So you may have the type of valve, you've seen this all before, you have the differences, and you've seen the difference in mortality already. We've heard this in the 2 previous presentations. So what about opening of tissue valves? And the difference, the mechanism, why is there a difference between survival, in survival between the 2 valve types, has never really been discussed in a way that related to hemodynamics, at least not in terms of quantitation. So if you take a valve that has a given outer diameter here, and you take a biological valve, then you have this. See, yeah, here. So if you have a, doesn't work. No, it works. I hope the video goes. Oh, video doesn't run. That's bad. Anyway, if this valve opens here, you can see an outer diameter and you see the opening area. And if you draw this, this is what it looks like. Okay? So you have this opening for this outer diameter. So if you have a mechanical valve that has the same outer diameter, you have this opening area because those 2 leaflets here, they barely obstruct flow. So bottom line is, valve opening area may correlate with survival. Mechanical valves have larger opening areas than tissue valves. Because if you have larger opening areas, you have less symptoms, you have less gradients. I mean, this translates into something that may actually affect survival. And that may also be the reason because we don't assess it properly so far. All the tools that we have used for measurement are camouflaged because of systematic errors and imprecision, and because we don't have the precise tools yet. And pressure gradient is certainly not the best tool either, but it may be the best that we have, but we don't use it. And that way, we end up with not knowing what the interest is, but we treat patients for gradients because the stenosis causes a gradient. It's not the stenosis that's the problem, it's the gradient that's the problem. And if we reduce the gradient, why don't we expect that we have a better survival, better outcome with better opening areas? So how do we compare valve types then? That's the next thing. So you all know putting a 19 is bad. Putting a 21, maybe 23, okay. Yeah, so there's different things. And then you have these pressure gradients that again are reported for the individual valve type. It's the same thing. It depends on the individual anatomy, because if you have a small lady of 150 centimeters, she may be well suited with a 19 valve that has a mechanical valve with a proper opening area. But the large guy that is 2 meters, he needs a 27 or 28 with a larger opening area. So if you look at the valves and then look at the labeling of it, and this is old stuff, these are all called size 23. So if you compare a size 23 Epic or Epic Supra with MitraFlow or Perimount, then you see they all have different outer diameters. So you can select between a 26 and 31 millimeters, 5 millimeters difference in outer diameter, all the same size. So one surgeon implants this valve here, and he says, that was easy, no problem. And the other guy puts this one here and says, oh, I have to enlarge the root or enlarge the aorta or whatever. It's only because the tools that the companies give you in your hand vary in the dimensions. And if you change valve type, all of a sudden, you experience differences. Oh, this is difficult. Yeah, because there are different diameters. There are different sizes on the outside, and that's relevant to the surgeon. So if you compare then based on manufacturer size label, outer diameter, or sizing strategy that is associated with it, then you end up with these different things here. And you can actually not compare anything. It's complete chaos. So how can you all put this together? And so the hemodynamics are currently best assessed with pressure gradients. That's it. Simple, but clean. That's the best assessment you can get. I'm convinced. The bigger the prosthesis opening area, the better. I mean, that's also natural, that's clear. And cardiac surgery is simple under normal conditions as far as I'm concerned. And the principles, once they're clear, they're there. And mechanical valves have the best opening area, and they may be the best choice at that time. But biological prosthesis can be upsized. That's also, you can correct for that to a certain degree if the anatomy is lost. I haven't shown you this, but I could. But anyway, maybe we have to move on in terms of time. So I'd like to conclude that for aortic valve replacement, implant the biggest valve opening area possible in every patient. And that's information that we don't have because we don't know how much this valve opening the valve area actually opens. Measure your success with pressure gradients, and I'd say PPM is relevant, but we're currently using suboptimal tools to assess it. Thank you for your attention.